The purpose of this Naked Truth video is to enhance, not replace, a consultation with your anesthesiologist. Our goal is to help you make an informed decision based upon the risks, benefits, and alternatives for your specific needs and desires. After viewing this video, you will be ready to have a more meaningful discussion with your doctor. It's important to remember that the decision to undergo a medical procedure or surgery must involve a commitment on your part to carefully follow preoperative and postoperative instructions. In the event of an emergency surgery or procedure, following postoperative instructions is critically important. Failure to follow these instructions may create serious complications and compromise your outcome. Obtaining optimal results from your procedure is dependent upon your understanding and active involvement in carefully following any suggestions or restrictions provided by your physician or medical professional. Remember that your personal commitment is just as important as selecting the best medical professional and choosing the right procedure. Even if you are the optimal candidate for a procedure and have the best technical care, failure to follow specific instructions can potentially adversely influence the overall result. This video contains graphic illustrations and nudity associated with medical procedures and is intended for adult viewers only.
Hello, I'm Michael Villani. With few exceptions, almost everyone has experienced some form of anesthesia, whether it involved a visit to a dentist, childbirth, a biopsy, general surgery, or a diagnostic procedure. You were probably grateful for the relief an anesthetic brought toward easing the pain or awareness of that procedure. But what do we really know about anesthesia? More importantly, what should we know? The video you're about to see addresses some of the most prevalent concerns and commonly asked questions about anesthesia. You will hear a detailed description of the role of the anesthesiologist, different types of anesthesia, procedures for which they're indicated, and how they're administered. We will include a variety of techniques used by many qualified anesthesiologists throughout the United States, accompanied by detailed descriptions of anesthetic alternatives available for the most common surgical and medical procedures. We will also discuss the benefits and risks associated with particular methods of anesthesia. Graphics and photographs will be used to illustrate ways in which anesthesia is used and the short and long-term effects you can expect. Actual video footage is included covering the pre- and post-operative consultation of a patient and her experiences as she undergoes a general anesthetic. A list of important questions you should expect to answer prior to being anesthetized, as well as those you may want to ask, will be included. We will also give you important guidelines to consider when evaluating an anesthesiologist for your particular procedure. Dr. Carl Novak, a respected anesthesiologist and recognized expert in his field, will provide you with the information needed to become comfortable and educated on this subject.
The Naked Truth About Anesthesia Home Consultation Series, available in VHS or DVD. Discount available for multiple tape purchase. Available at www.nakedtruth.com or by calling 1-877-NAKED-TRUTH. Be sure to look at our website for the other tapes available in our comprehensive medical and dental Naked Truth library. Watch for our growing list and order them from www.nakedtruth.com. Physician, teacher, author, researcher, and forensic specialist. All of these describe our expert anesthesiologist, Dr. Carl Novak. Dr. Novak is widely recognized as one of the country's leading anesthesiologists and is considered an authority in this highly specialized area of medicine. The accomplished Dr. Novak was elected as the ETA, Extreme Team Anesthesiologist, as he was featured on regular appearances on ABC's television hit, Extreme Makeover. He has been referenced on CNN, including on video on Larry King Live, seen on MSNBC, and featured in Touch Weekly. Dr. Novak attended Yale University, where he was recognized as a Yale National Scholar. He went on to receive the distinction of becoming a member in the Alpha Omega Alpha Medical Honor Society at the University of Missouri Kansas City School of Medicine. After completing his residency at the prestigious Mayo Clinic in 1980, Dr. Novak became certified in anesthesiology with a subspecialty in pain management. His academic appointments have included the Mayo Clinic, Emory University in Atlanta, University of Nevada, and most recently a faculty member position with the UCLA School of Medicine. Carl continues to teach and train other physicians both directly and indirectly, from one-on-one coaching to lectures and book chapters, and has been published in highly respected medical journals and periodicals worldwide. His most recent publication is featured in the authoritative text edited by Melzack and Wall, The Handbook of Pain Management. Dr. Novak has extensive experience in clinical research where his primary interests include extended duration outpatient surgery, disc repair and spinal surgery, and information technology as applied to anesthesiology. Dr. Novak has been a managing partner of Forensic Associates, a firm providing litigation support to attorneys. In his work as a medical forensic consultant, he is recognized as having built substantial experience and unsurpassed expertise, providing testimony used in assessment of injury causation and evaluation. He is considered an expert in many areas, including anesthesiology, pain management, neurosurgery, orthopedics, and neurology. In addition to ongoing work in forensics, Dr. Novak manages a busy private practice in anesthesiology and pain management in Beverly Hills. There, he provides exclusive anesthesia services for renowned plastic surgeon Dr. Garth Fisher.
Hello, I'm Dr. Carl Novak. You may not recognize me, but if you've ever had surgery, I may have held your life in my hands. I'm an anesthesiologist. If you're interested in or have purchased any of the Naked Truth Medical series of DVDs or videotapes, then you are likely considering elective surgery or anticipating a need for a surgical or medical procedure. Once you're committed to having any surgical intervention or medical procedure, you're also most often committed to undergoing some sort of anesthesia. For this reason, I want to familiarize you with the critical role assumed by the anesthesiologist within the context of patient care and comfort. Patients rarely think of the anesthesiologist's impact on their surgical event. We practice in nearly complete anonymity, almost as an extra in the surgical setting. In the movies and on television, we have a ghost-like quality floating on and off the set. Until a complication arises, we are just the person behind the mask. Prior to the day of the procedure, many patients are unaware that they even have issues or concerns regarding anesthesia. Yet when discussing anesthesia with patients preoperatively, it's obvious that there exists intense, if unexpressed, anxiety as patients anticipate the unknown and loss of control. Will I be awake during the procedure? Will I have any awareness of what's going on during the operation? What if I never wake up? Will I have nausea or vomiting afterward? What will my pain be like after surgery? Do you have to put a mask on my face? Why does it hurt to start an IV? Can my friends and family be with me? How long will it take to recover from the anesthetic? Will you be with me the whole time? These are perfectly reasonable questions. You're putting your trust in a stranger whom you may not have previously met. This person then renders you unconscious, semi-conscious, seriously sedated, or at least partially numb for a surgical or diagnostic procedure. The goal of this video is to resolve these and other concerns for you. We will help familiarize you with the role of the anesthesiologist, different types of anesthesia, and varied anesthetic techniques along with their inherent benefits and risks. After viewing this video, you'll have a working knowledge upon which to base your questions and evaluate potential providers. You'll also get examples of questions that will be asked of you and understand why open communication is so critical to a positive outcome. Let's begin now to demystify anesthesia at its very root.
What is anesthesia? The word anesthesia is often misunderstood. It's derived from modern Latin, which in turn was rooted in Greek, meaning literally, lack of sensation. Simply put, anesthesia is a medically induced insensitivity to pain. This is different from analgesia, which means to reduce pain or to make one feel better. Novocaine is an anesthetic. Ether was an anesthetic. Laughing gas helps with anesthesia, but is not really one in itself. Narcotic pain medications can be anesthetics. Aspirin is an analgesic. Ibuprofen and Tylenol are analgesics. Just knowing how to categorize a medication can be difficult for the patient. The first recorded use of anesthesia dates back over 5,000 years ago. The Egyptians actually performed brain surgery. You can be sure it was not done on patients who were fully awake. While trying to defeat the Holy Roman Empire, Hannibal's troops used ice for numbing and primitive cauterization techniques to stem bleeding while crossing the Alps. Opium was used by the ancient Greeks to relieve pain. Local anesthetics were created by the Greeks and later the Romans by mixing the stone of Memphis with vinegar. Herodotus, a Greek historian, reported the production of a state of anesthesia by breathing the fumes of burning hemp. Modern anesthesia has its roots in the United States. Joseph Priestley, who discovered both oxygen and nitrous oxide, moved to Pennsylvania in 1794. Uses of ether and nitrous oxide, generally for recreation, developed in the USA in the early 1800s. The first documented general anesthetic was March 30, 1842, when Dr. Crawford Long of Jefferson, Georgia, removed a tumor from his friend James Venable's neck while Venable was under the influence of ether. On Friday, October 16, 1846, at the Massachusetts General Hospital, Dr. William T.G. Morton administered an ether anesthetic with an anesthesia machine to Gilbert Abbott for the removal of a jaw tumor by Dr. J.C. Warren. The age of modern anesthesia had begun. The international acceptance of anesthesia was assured when in 1853, Queen Victoria received a chloroform anesthetic for the birth of her 8th child, Prince Leopold.
Different methods are used to achieve anesthetic states. The procedure, the patient's health, physician preference, and a particular anesthetic's availability are key influences in the method chosen. An epidural given to ease the pain of childbirth is very different than the anesthesia prescribed for open heart surgery. Throughout this presentation, we will consider anesthesia in the context of common surgical interventions and medical procedures.
When unconsciousness and total insensitivity to pain are the goal, anesthetic gases or intravenous agents are used to create a general anesthetic. Sometimes the procedure calls for a regional anesthetic where only a portion of the body is numbed. Local anesthetics work on or about the nerves in situations such as dental or eye surgery where only a very specific area is targeted. Local anesthetics and sedation are often used in tandem with regional and general depending on the procedure. Other, less conventional techniques such as acupuncture and hypnosis have been reported to contribute to an anesthetic-like state, but we will not be discussing these in this presentation. Who is an anesthesiologist? An anesthesiologist is not simply someone behind a mask who gives you medications to put you to sleep. He or she is responsible for maintaining your life during the surgical or diagnostic experience and caring for you in recovery. The anesthesiologist has control of your brain, heart, lungs, liver, kidneys, vascular system, GI tract, everything except the operative site during your surgical event. An anesthesiologist is a medical doctor with a degree of MD or DO. Despite being physicians, anesthesiologists are routinely asked if they attended medical school. Typically, a trained anesthesiologist will have completed college in roughly 4 years, gone on to medical school for approximately 4 years, and then completed a minimum of 4 years in postgraduate training. A total of 12 years post-high school study is typically required to become an anesthesiologist. While the usual training program is 1 year shorter than that of a general surgeon, it is 1 year longer than the program required for internal medicine. The postgraduate medical training includes 1 year of internship, providing experience in the emergency room, intensive care, internal medicine, and surgical specialties. The next 3 years are spent in a residency program under the supervision of fully trained physician anesthesiologists. Many candidates sign up for an additional 5th year of subspecialty training in areas such as pain management, cardiac anesthesia, obstetrics, pediatrics, or critical care. As you can see, anesthesiologists are highly trained medical specialists. In summary, we must emphasize that an anesthesiologist is first and foremost a physician, secondarily a specialist in the field of anesthesia, and often a subspecialist in a further defined area of medicine.
Beyond administering medications to render patients insensitive to pain, the anesthesiologist has other roles. One of his or her primary roles in the operating room is to assist the surgeon in making sound medical judgments as they relate to the patient's proposed surgery. To do this effectively, the anesthesiologist needs to have a fairly detailed understanding of the surgery itself. While the surgeon has the technical and artistic skills to complete the operative task, the anesthesiologist must have roughly equivalent intellectual skills to understand the sequence of the surgery and manage its impact on the patient on every level. Waiting to respond to an emergency is hardly the best way to address the situation. Therefore, the anesthesiologist must anticipate pitfalls and proactively take steps to assist the patient's well-being prior to the occurrence of an adverse event. The anesthesiologist and surgeon are qualified experts in their respective fields working together in team fashion to provide the best possible care for you. As a fully trained and licensed physician, the anesthesiologist is very capable to serve as the guardian of the patient's welfare during the surgical event. His primary role then is to be your advocate and caregiver before, during, and after surgery.
What is the anesthesiologist's role prior to surgery? You may be surprised to learn the anesthesiologist is the physician who clears you for surgery. Your anesthesiologist therefore needs your full disclosure regarding any questions asked about your health, no matter how personal or irrelevant those questions may seem. In essence, just as the surgeon and the anesthesiologist are teammates during surgery, the patient and the anesthesiologist are teammates prior to the surgery. One of your most important roles as a patient is to establish and maintain open and honest communication with all your physicians. In the absence of full disclosure, the anesthesiologist cannot be your advocate and cannot make the best possible recommendations regarding your care. In fact, being less than honest about medical problems and medications can lead to catastrophic events in the operating room. Why is it so critical to be forthcoming about medical problems? The anesthesiologist is reasonably required to make a preoperative assessment of the patient prior to administering any anesthetic. For this reason, general medical clearances performed by internal medicine doctors are redundant. While preoperative evaluations by subspecialists may be valuable, the surgeon and the anesthesiologist are the two physicians most fully aware of the steps involved in the surgical intervention. Anesthetics are not cookbook formulas where standard recipes suffice for the majority of patients. Patients are treated as individuals. Just as operative plans are tailored to the patient, anesthetic plans are similarly unique. So, what can you expect to be asked? Knowing your medical history and current medical status at the time of surgery is very important to your anesthesiologist. Here's an example of a preoperative history questionnaire you may be asked to fill out and sign. Included are questions on medical history, past surgical history, current afflictions, current medications, and allergies, among other things.
Medical history is relevant because it may help red flag adverse interactions with either medical or disease states that the patient may have. Surgical history is important to know for two reasons. One, to analyze your response to certain anesthetics, and two, to determine if anesthesia will have any impact on former surgeries from a physical standpoint. If you have a family history of malignant hyperthermia, your internal thermostat during surgery will need very close attention. Likewise, any liver, kidney, or heart disease can contribute to organ system failure when certain anesthetics are used. The best predictor of future response is past response, so avoiding drugs or situations you did not like or had problems with helps you. If a certain drug caused you to become nauseated, for example, attention is required. If something did not work for you, like a local anesthetic or pain medication, an alternative needs to be found. For some surgeries, certain drugs need to be avoided. For instance, nitrous oxide and neurosurgery do not generally mix well together. If you've had a previous shoulder surgery, we may not want to use a certain type of arm board. It takes years to learn these interactions and issues, so we do not expect to address every eventuality here. But these are the types of situations your anesthesiologist must consider in planning your anesthetic.
There may be drugs to which you are truly allergic. There may be drugs to which you have a poor response. Your physician may be considering anesthetic drugs that negatively interact with some surgical procedure you have had. For example, some medications used to treat nausea and vomiting postoperatively may have an adverse effect in those patients who have undergone gastric bypass or other weight reduction procedures. You will be asked about allergies. Included in your list of allergies should be drugs to which you are particularly sensitive or that you do not wish to receive. Although sensitivities are not classified as true allergies, it is important to disclose all medications that in any way do not agree with you. For instance, one of the most common anesthetic induction agents has sulfites in it. People with sulfite allergies should not have this medication. It may alter the choice of whether to use generic or brand name propofol. Propofol is a popular agent used to get you off to sleep and in some situations maintains anesthesia for surgery. A history of asthma or bronchial constriction may lead the anesthesiologist to choose different classes of muscle relaxants. Some muscle relaxants cause the release of histamine. People sensitive to histamine, those experiencing a fall in blood pressure or an asthma attack with histamine, should not have histamine-releasing muscle relaxants without pre-treatment for the problem. Your medical intake forms will also request that you identify any prescription medications, non-prescription medications, and even diet supplements, vitamins, and herbal remedies that you may be taking or have taken relatively recently. There is a potential for unexpected adverse interactions when you are or have been taking any of these non-prescription medications and do not disclose the fact prior to receiving an anesthetic. Most people understand the importance of disclosing prescription drugs such as antidepressants or cardiac medication. What much of the general public fails to realize, however, is the powerful effects of some over-the-counter medications and supplements when coupled with anesthesia. Acetaminophen can be toxic to the liver if inadvertent excessive doses are given. Combining over-the-counter medications containing acetaminophen, Tylenol's generic name, with other prescription medications involving acetaminophen in the postoperative period can be dangerous. Seemingly innocent over-the-counter supplements such as echinacea, used to boost the immune system and help fight colds, can cause inflammation of the liver. Aspirin and non-steroid anti-inflammatory drugs such as ibuprofen, Motrin, or any of their relatives can increase bleeding during surgery. Vitamin E is beneficial in preventing blood clots, but this same benefit can turn to a liability when it increases blood loss during surgery. Garlic has many beneficial effects, but may also increase bleeding during surgery if patients are already taking aspirin, non-steroidal anti-inflammatory drugs, or prescription anticoagulants. Both garlic and St. John's wort may reduce the effectiveness of certain types of drugs used to treat HIV and prolong the effects of anesthesia. All of these medications need to be stopped prior to surgery. Most adults are currently aware of the problems with ephedra or ma wong. This supplement has now been withdrawn from the market. However, hyperresponsiveness to certain surgically used and anesthetic drugs may persist for years after the exposure to ephedra.
Our purpose is not to scare you with an exhaustive list of do's and don'ts, but to emphasize that seemingly trivial habits and otherwise innocuous over-the-counter products may have a major effect when coupled with anesthesia.
Often, patients ask what to do about their daily medications. This question is highly individualized and not subject to a standard answer. Certain medications need to be stopped at least 10 days before surgery, such as aspirin and anti-inflammatory drugs. Others may be stopped 2 or 3 days before surgery, such as anticoagulants or stroke prevention medications. Heart, blood pressure, and diabetic medications can usually be taken the day of surgery. These may or may not need to be injected, depending upon your doctor's instructions for eating and drinking the day of surgery. In each and every case, the directions given to you regarding the cessation or continuation of medications prior to surgery need to be tailored to your situation, surgeon, and surgery. Beware of blanket generalizations. The anesthesiologist will often review laboratory or diagnostic tests that have been ordered to provide indications for surgery. Supplemental tests may be required if necessary. Inpatients are often admitted the day of surgery, leaving little time to resolve any issues. The preoperative evaluation has become all the more important because it is often the final step before entering the operating room. Prior to undergoing surgery, the anesthesiologist is your last defense against a complication. At this point, you may be curious as to when you might see or hear from your anesthesiologist. Pre-anesthetic care really begins prior to surgery with patient contact. If at all possible, your anesthesiologist will contact you before your admission to the hospital or surgical center. This isn't usually difficult since surgical schedules are typically produced well ahead of time. Sometimes the anesthesiologist will meet you in the office, and other times you may be contacted by telephone. The preoperative visit may take place several weeks prior to surgery or the night before. It may even be the day of your procedure. In any case, it is an opportunity for a mutual introduction. At the very least, you should expect a thorough discussion of things anesthetically related prior to receiving sedatives or preoperative medications and before signing a consent for anesthesia. You will need to sign a specific consent for anesthesia as well as a consent for your procedure.
If your preoperative conversation takes place before the day of your procedure, you will review any laboratory and diagnostic tests, talk about the anesthetic plan, arrange the timing of any daily medications, and make sure you are clear on the protocol for eating and drinking prior to surgery. Historically, there's been a general rule prohibiting eating or drinking anything after midnight the night before surgery. Primarily, this has been to lessen the amount and acidity of what is in your stomach when your anesthesia is begun. The intent is to lower the chance that stomach contents will get into your lungs, or aspiration pneumonia, during anesthesia and surgery. More recent studies have shown increased safety and better outcomes with having liquids up until approximately 4 hours